Okay. Check on this. It must be military planes flying over. Let's see. Keep hearing that every so often. Not here yet. All right, cool. Message her. All right, and did I get my, let me download this again. I have it on here somewhere. All right, so we looked at a couple of videos on Monday. Have y'all had a chance to look at chapter 4 at all?
No, I actually got to go to the Apple store today because my laptop stopped working. So I have an appointment to get it fixed because it's not charging. So I don't know if my charger is bad. I mean, I still can do it on my phone, but it works really slow on my phone when I'm doing my work.
Yeah.
But I have an appointment today after class.
Gotcha. Okay, let me see. We went through dermatologists. We were talking about all the different lesions. We talked about skin cancer. So quick review. Differences between a esthetician and a dermatologist. You can just shout them out.
Dermatologists, they diagnose, and esthetician
treat skin.
Yeah, we
You said treat skin
and recommend
Skin.
Mm-hmm. The differences between what we treat and what a dermatologist treats, because we can both treat. We both have licenses to treat. What's the difference between what we treat and what they treat?
Our treat is more off of recommendations. I believe.
What kinds of things can we treat and what kinds of things do they treat?
Dermatologists take on more severe, I guess that's the word. I've been a dermatologist, more severe cases of, I guess, like acne and skin problems.
more things that's like internal
medicine stuff, yeah.
So here's a way to think about it. And this is probably what we're all saying, kind of saying and thinking the same thing. So we're here studying what this chapter, diseases and disorders, right?
Mm-hmm.
So mainly they can diagnose diseases and disorders, and most of what they treat is diseases and disorders. We treat skin. Can y'all hear that?
types.
Y'all probably don't hear it. Okay. It sounds like a plane flying overhead. It's really loud and it's really quick. So I think it's a military base nearby, and I think it's a military plane flying over every so often. It's like super loud. I don't know if y'all could hear it. So we treat skin conditions. Remember we were talking about conditions versus
Types.
Last chapter we were talking about conditions versus skin types, but we would treat skin conditions. They treat skin disorders and diseases. We don't treat skin disorders and diseases because we can't diagnose disorders and diseases. So why are we talking about disorders and diseases? Because we can recognize, we observe, and we can recognize. What I didn't have with me the other day, and I just happened to see one sitting here, so I'm going to show it to you, but I have one, and we'll use ours. We'll use mine when you get here. Y'all know what this is?
What is that?
Y'all know what this is?
No.
Turn it on, and you will put your client I'm gonna pull this cover back.
The magnifying.
There is a purple light here. And you would put your client underneath this.
Is it a woods lamp?
It is. It is a woods lamp. So we can come up on this and kind of look at their skin. And actually, I'm gonna plug it in. You can see what it looks like. And your client goes under the hood here, and it's just a little it's just something you just pop right on. It's got elastic, and you pop it right on. Put your client's face in there, turn the light on, and you're looking in the window at their skin. This is what it looks like inside. Right? So if I was the client, I didn't disinfect this, I just picked it up off the thing. But if I was the client, let's see how this works on Zoom. Pin me. Y'all know how to pin somebody on Zoom? I don't know if you can do it or not, but if you hover over a picture, you should see mute. You should see two blue buttons that say mute, and then the other blue button has the 3 dots on it. If you click on the 3 dot button, drop-down menu will come up, and one of the options is pin. If you hit that, I should become the main thing on your screen. So my view, instead of us looking all of at our thumbnails, my view should be the main view on your screen.
Okay.
So let's see if y'all can, let's see how it looks on Zoom. Who knows? We'll do this later. Can you see my thing?
No.
Yeah.
Not at all.
All right. But this is what happens. So you put your client in there and you're able to look on them, and the purple light highlights stuff that's going on: dry skin, acne, hyperpigmentation, all kind of stuff. So we'll look at this when you get here, because I have one, so that's cool. So it would have been nice if I had mine handy when we were talking about skin analysis. So when you get here, when we actually do skin analysis, I will have my woods lamp and you'll be able to learn how to use it. Hey, Maris, I'm glad you made it.
Hi.
So just happened to share that with you. Here's some other neat stuff. I have coffee. I need to move. It just so happens that I'm at the front desk, obviously, at Lotus. And another neat thing that we just happen to have sitting here is a microdermabrasion machine. So that's pretty cool. And when you get here, we're going to be doing microdermabrasion. So it just happens to be sitting here. I'm at the front. I'm not even in the back. Okay. So, all right, we were just reviewing what we covered before going into new stuff. We were talking about the difference between the dermatologist and an esthetician. So they diagnose disorders and diseases, and they treat disorders and diseases. Do people go to them for skin conditions as well? Yes.
Mm-hmm. Yes.
Should they be going to an esthetician? Probably. They should probably be going to an esthetician. But that's the importance of educating yourself past school and understanding how to treat conditions, how to treat skin of color, how to treat problem skin. Acne is a whole situation that you could just study that. So much to acne. You could just be an acne specialist. You could be a hyperpigmentation specialist. You could be a skin of color specialist. You could be a chemical peel specialist. You can specialize in anything that you want to, or you can specialize in a few things. So continue your education beyond school is very, very important. That's why I stay in classes. All right, so that was that. And then we also were looking at what else? Primary, secondary, and tertiary skin lesions. What's the main difference between, how do we know when we're dealing with something that is primary versus secondary versus tertiary? How do we know? What makes the difference? What's the differentiating factor between primary, secondary, and tertiary?
Is it how deep it is in the skin?
Absolutely. So primary is where it's found where?
The surface?
Which we call
Like the epidermis.
epidermis. Secondary is largely in the what layer of skin?
Is that the epidermis?
Nope, that's primary. You just said that one correct.
Oh.
Primary lesions are found in the epidermis. Therefore, secondary lesions would be found where?
Is it the dermis?
In the dermis. And then tertiary lesions are found where? It's on the screen. What's beneath the dermis?
Where is it on the screen? I don't see it.
Are y'all seeing my screen where it says types of lesions?
Yeah, I see the types of lesions.
Down here, it says tertiary lesions are vascular lesions, which involve the blood or circulatory system. So basically they are hypodermis, they're below the dermis. Below the dermis is subcutaneous layer, your vascular layer, you know what I'm saying? Your blood vessels and all the stuff that's deeper than the skin. Does that make sense?
Yes.
Primary, epidermis, secondary, dermis, tertiary, beneath the dermis. So in the body, in the system, in the systemic system, circulatory system, all of that. So we have our primary lesions. We watched a video on these, right? We have a bulla, which is a large blister containing water, a cyst, which is an abnormally developed sac containing pus, semi-fluid, or some other type of matter. Macule is a flat discoloration of the skin, like a freckle. Nodules are a solid bump larger than 0.4 inches. Like examples would be like a swollen lymph node. We have papules, which are small elevations on the skin that have no fluid, but may have pus, like acne, warts. Pustule is a inflamed papule. So now it has a yellow or white center because it has pus in there. So like cystic acne or folliculitis or impetigo. Tumors, abnormal mass that vary in size, shape, and color, may or may not be cancer. But the main example of a tumor is cancers. Vesicles are small blisters or sac containing clear fluid, like poison ivy, poison oak. A wheal is a small, itchy, swollen lesion that may be caused by a scratch or a bite of an insect or an allergy. So examples are like mosquito bites or hides. That's a wheal. Those are the primary lesions that you need to know. Secondary lesions, crust, which is like a scab from a wound, excoriation, a skin sore or abrasion produced by scratching or scraping, like cuticle damage from nail biting. Fissure is a crack in the skin, like chapped lips, feet, hands. Keloids, we know what those are. Those are thick scars resulting from excessive growth of fibrous tissue. A scale, thin, dry, oily plate of epidermal flakes, like dandruff or psoriasis. Those are considered scales. A scar or cicatrix is a slightly raised or depressed area of the skin. A scar, like from post-op. Ulcer, an open lesion in the skin or mucous membrane of the body, accompanied by a loss of skin depth. So an ulcer usually dips into the surface of the skin, right? So like chickenpox or herpes are considered ulcers. So those are your secondary lesions. We talked about skin cancer. What were the 3 types of skin cancer? Can you remember? There's 3 types and they vary in how often they occur and how dangerous they are. Do you remember those?
Number 1 was melanoma.
Malignant melanoma. So if we start on that end of the spectrum, malignant melanoma, does it occur often or is it rare?
Rare.
It's rare, the most rare of the 3. And then how does it range in its mortality, morbidity? How dangerous is it?
It's very deadly.
It's the most, right? Most dangerous. What's another type?
Basal.
Basal cell carcinoma. Okay, tell me about those two characteristics.
I know it's the most common.
Most common, correct.
Is it the least
Least
deadly?
dangerous. Least deadly, yes. And what's the third one?
Squamous.
Squamous cell carcinoma, SCC, correct. And so it's the one in the middle, right? Basal cell carcinoma is the most commonly occurring, least dangerous or least deadly. Basal malignant melanoma is the most rare, but the most deadly. And squamous cell carcinoma is in between, right? On both. Good. What else? So we did those three. Oncology aesthetics, we didn't really talk about that since we're finishing up and moving on from skin cancer. So it's a special niche that has emerged for estheticians called oncology aesthetics. So this is treating skin that's been exposed to radiation and chemotherapy. It requires a depth of knowledge beyond basic aesthetics, obviously, right? The skin can be much more fragile and reactive. And additionally, you don't want to provide any treatment or skincare products that can be contraindicated with their cancer treatment. So you definitely have to get additional training for that because, funny enough, cancer is a contraindication for a lot of advanced aesthetic treatments, right? So if as soon as someone says, well, I'm a cancer survivor or I have cancer, you say right off the bat, oh, but I can't treat you for this, I can't treat you for that. So obviously, the field that is dedicated to treating those folks is really specialized, and so it requires a lot of additional training. The ABCDE cancer checklist, again, you want to train yourself to be able to observe and recognize when something doesn't look right, because you want to be able to encourage your client to go seek medical treatment, to get checked out, make sure they're okay. So we need to recognize. While we don't diagnose, we need to recognize. So the ABCDE cancer checklist helps us to recognize. So when we're checking moles, we see a mole and you're like, is that something? Is that something, right? So you're looking to see for asymmetry. So ABCDE stands for A is for asymmetry. What does asymmetry mean?
It's not the same on both sides.
Correct. Symmetric, something that is symmetric is something that's even, right? So if it's asymmetric, that means it's not even, it's not equal. So the two sides of the lesion are not equal. The border is irregular. It's not a nice, even, smooth, circular type of lesion, but it's like jagged, like that last one. Okay. Color. Melanomas are usually dark. They may have more than one color or colors that fade into each other. So if you can see the ones on the bottom, the 3 melanomas, you can see that there are multiple colors there. It's not a smooth color. So we're looking at color for C. Diameter. The lesion in a melanoma is usually at least the size of a pencil eraser. Something smaller than that is more than likely not a melanoma. And evolving. Melanomas change appearance. So that's the number one thing I was always remembered to be taught, is that you want to watch something. I'm going to share something with y'all too. You want to watch it. If something stays the same for a long time, it's probably not melanoma, because melanomas are known to change. So when you see something, a lot of times we're told to watch it. And you're number one watching for changes. If something changes, is changing, that means it's doing something, it's active, right? So I'm gonna show y'all something real quick. I think I can show y'all here. This right here, I don't know if y'all can see it. This has been here for years. It's pretty flat, but there is a little bit of texture to it underneath. It's flat on the surface, but when I do all of this palpating, there's a little texture to it. When I first saw it, I was like, I did not like the color because, I'm kind of light skinned, sort of. So I literally have watched this thing for years and it hasn't changed in years. I still eventually want to get it checked out, but that's one thing that I don't have a whole lot. And I don't have a lot of don't have a lot of cancer in my family, thank God. And I don't have a lot of, I don't know any instances of skin cancer. So I just been watching. But I first saw this like 3 or 4 years ago, 2 or 3 years ago, and it hasn't changed. So you want to watch stuff. That probably the E is the most important thing because melanomas change and they change pretty quickly over a small period of time. All right. So these are important things you can tell your, you know what I mean? Like you can kind of even share this information with your client. If you see something, you tell them this stuff. This is not diagnosing what they have. This is just giving them information. Does that make sense? Little things that you can do to help and that might make a difference. All right. We talked about the different types of acne. How many levels of acne or grades of acne did we mention on Monday?
Is it 6?
Nope. Nope, not 6. Dang, I did not bring my cord for my laptop and I was like, I'm not gonna run out of juice. I always plug it up and it's always full and it is going down my battery. It's 4 grades of acne. Excuse me, let's see. 4 grades. So initially we talked about how grade 1 is minor breakouts, some closed comedones, some open comedones, and a few papules. Grade 1 is mild. Grade 2, many closed comedones, many more open comedones, occasional papules, and some pustules. Remember, a pustule is an inflamed papule. Papule is just kind of a bump. And then a pustule is an inflamed papule. So instead of it being like skin colored or maybe a little reddish, that one is white or yellow color because there's pus in it, right? And then grade 3, red and inflamed, many comedones, many papules, many pustules, which is that grade 3 picture up there. And then grade 4 is all out cystic acne. So cysts with comedones, papules, pustules, inflammation, scar formation, and hyperpigmentation from skin damage is very commonly seen with that one. Okay. Let's see, was there something I needed to go back up here? So by definition, it's an inflammatory skin disorder. Goes through the inflammation process, you'll find papules, pustules, and cysts. All right. We just talked about what those are right here. Sebum can cause irritation and inflammation. What is sebum again?
Oil.
Oil, right? Bacteria and inflammation will increase, putting pressure on the follicle wall. So the rupture wall becomes infected, causing debris to spill into the dermis, which causes that inflammation. So the redness and inflammation is caused when the white blood cells fight infection. That is the inflammatory process that basically causes what we think of as acne. We talked about papules being the little red inflamed lesions. Pustules are filled with fluid from the dead white blood cells that fought the infection. So it's pus. And then cysts are nodules made of deep pockets of infection. So those are the 3 things that you'll see occurring in acne. The pilosebaceous unit is the entire follicle. So you look at a picture of a hair unit, they call that the pilosebaceous unit. So it's the entire hair follicle, including the hair shaft above the skin surface, the sebaceous gland that's attached to the hair follicle, and the sebaceous duct or canal that leads to the surface. I'm surprised we don't have a picture of it here, but when I see it, I will share that as well. Some factors that cause clogged follicles is what leads to acne, is excess oil. So we need to manage our oil on our skin, just like we manage our transepidermal water loss. We manage all of those things. We need to manage the excess oil. If we're very oily, we're going to be prone to acne. Retention, hyperkeratosis, sebaceous filaments. We're going to look at that in a minute. primary place where we find sebaceous filaments is on the nose. And then the opening of the follicle might be too small to let impactions out. So then they'll get clogged. These are the reasons why we end up with clogged follicles. Types of clogged follicles. Have you ever seen skin that looks like this? You just want to do extractions. I don't know how y'all are, but I see skin like this. I just want to get my extraction tool and my gloves and get to work on that skin. I want to pull all that mess out. All right. So comedones are plural. The singular of comedones is comedo, an inflamed buildup of cells, sebum, and other debris inside of a follicle. So an open comedo is a blackhead, open at the surface, exposed to air. This is what we're looking at right here. A closed comedo forms when the opening of a follicle is blocked with debris and white cells, and so therefore it's referred to as a whitehead. So we have whiteheads, that's a closed comedo, and a blackhead is an exposed or open comedo. Do we understand the difference there? Open comedones are blackheads, closed comedones are whiteheads. Sebaceous filaments are also seen here in this picture. They're the small, solid, solidified impactions of oil without the cellular matter. So you ever seen when you're extracting and just the little white stuff comes out? It doesn't look like pus. It doesn't look like thick with cells. It doesn't look like it's got a whole bunch going on. It's just a little bit of oil that you're pushing out. Those are sebaceous filaments, right? Often found on the nose. That's why you see me doing this, because when we think of sebaceous filaments, for me, I think of like extracting the nose. Milia is interesting. Milia are these little bumps that you see oftentimes around people's eyes, under the eyes or around the eyes. They're very, very hard to treat. So they're small epidermal cysts that appear as firm white papules. Sometimes they look skin colored. They don't look white. Sometimes they look like the color of the client's skin. Whitish pearl-like masses of sebum and dead cells under the skin, no visible opening. So a lot of times, so it says mistakenly called whiteheads. Untrained eyes will confuse milia with whiteheads. Whiteheads are which ones? Closed or open comedones?
Closed. Open.
Nope, you said it right first. Open are black. Open are black and closed are white. I feel this little bump here and I can't tell if it's milia or not. Camera. I'm gonna take a picture of it. I don't even know what it is. Oh, I have so many, and I have so many freckles. You can't tell. Like my blemishes be blending in with my. Okay, yeah. So if I blow it up, it gets blurry. So can y'all see this? This is not the best camera. Can you see this little bump?
I can't.
No.
No, it's too small. It's not the best camera. This to me, I'm looking at a picture of it. This looks like it could qualify as milia. And milia, you start seeing in people when they get old. You know, I'm always talking about being old, right? I'm old. I think what I just, and I took a picture of it. I think what matter of fact, I could text it to the group chat. That might be a better way for y'all to see it on your phones. So I think that qualifies as milia because it's not acne. It's hard, it's whitish, and it feels like one of them things that ain't going nowhere. And that's a lot of times how I would describe milia. It's that bump right above my nail. I don't know if y'all can see it. So, it's also seen in newborns after birth. It can be caused by blocked follicular openings from an oil-based moisturizer. And I've always used oil-based stuff on my face because I historically have dry skin. Treatment for milia is increased exfoliation and using a retinol product. So we product treat these because it's very hard. Sometimes, depending on, that's why it says check with your state for rules and regulations, because in some states you can use an extraction tool to make a tiny opening into the epidermis to expose the milia. So I've seen this when I went to SkinScript, they were talking about milia a lot and how difficult they are to treat. So they practice treatment with products. Usually things like enzymes and chemical peels to break it down. But in some cases, if you have a sharp extraction tool with a point, you can, pierce it and maybe try to extract it. They're very hard to extract. You can really complicate your client's skin if you get too caught up in trying to treat milia physically. because they're pretty hard and they generally kind of act like they're not going anywhere. Did the picture come through?
Oh, yes.
Yeah.
Check our
Okay,
group chat. You see it, that little white bump?
it's so small.
I know, I could just feel it. I didn't even know it was there. I'm always feeling my face. Seven always says, stop touching your face, stop touching your face. I'm a face toucher. So I was just touching it as we were talking about it. And I was like, this bump feels hard. What is this? I couldn't see it, but I took that picture. I think that would qualify. It feels very hard. And so I'm like, that's one of them things I don't mess with. Sometimes estheticians can mess themselves up trying to mess with milia. Milia are very hard to treat. Okay, other types of clogged follicles, retention hyperkeratosis. Retention hyperkeratosis. Osis is a word part for abnormal condition. Kerato is the word part for what? When we talk about keratinocytes and keratin, what are we talking about?
I'm getting a little bit stressed.
Is keratin like a protein almost?
Keratin is a protein. Keratin is a protein found in the skin. Keratinocyte is basically the clinical term for a general epidermal cell. So oftentimes we talk about melanocytes when we talk about, pigment and hyperpigmentation and all that. So melanocytes are found down in the dermis. Keratinocytes are the cells that are found in the epidermis. So we're talking about what's going on in the epidermis. We're talking about keratinocytes for the most part. There's lots of different types of skin cells, but they are the main skin cell. They're an old skin cell. They're filled with keratin, the protein. They're at the top layer of the epidermis, and they're hardened, and they are the next set of cells that slough off the skin. Okay, so hyper means what? We talked about hypo and hyper Monday. What is hyper? Over, excessive, large amount, right? So when you see these big words, I want you to think, this is how I taught my medical classes back in the day. Just break the word down. Retention hyperkeratosis, sebaceous hyperplasia. That sounds like, ooh, just break the word down. So it's a hereditary tendency for acne-prone skin to retain, hold on, keep dead cells in the follicle. So it's forming a clogged follicle. It's the hereditary tendency, general tendency, natural tendency for acne-prone skin to retain its dead skin cells in the follicle. Therefore, it's forming an obstruction, clogs the follicles, and exacerbates an inflammatory acne lesion like a papule or a pustule. Does that make sense? Retention hyperkeratosis. Does that explanation line up with the word part breakdown?
Yes.
Okay. Let's look at sebaceous hyperplasia. Plasia is a word part for growing, like skin growth. Hyper means excessive. So right off the bat, hyperplasia means what?
Excessive.
I
guess that the word hyper in it is like excessive.
Excessive. And then plasia refers to the growth of skin or the growth of any anatomical structure. Bone growth, muscle growing, anything that's growing, growth is plasia. So hyperplasia right off the bat means what?
Like excessive skin growth.
Yeah.
Overgrowth or excessive growing, too fast or whatever have you, right? So then sebaceous means what?
Like oil.
Referring to oil. So right off the bat, when I see a big phrase, I'm breaking it down and I'm like, this should mean, based on its word parts, it should mean this. Now we look at the definition. A benign lesion frequently seen in oilier areas of the face. They're often white, yellow, or flesh colored. Cryotherapy, surgery, or laser excision are recommended treatment. So benign lesion, frequently seen in oilier areas of the face. So it's a lesion. It's benign, which means what?
It's good, like it's not bad.
Yes, it means non-cancerous. It means it's not deadly. Not necessarily good, because anything that you have that's considered benign means it's something that's there and it's probably an annoyance, but it just means it's not cancerous. So correct, seeing the oilier areas of the face. I think there could be a better definition for that, but that's the one that's given here. And then seborrhea. Rhea is a word part that means like leaking, like a leakage. And then sebum, sebo is a word part for sebum or oily. So a severe oiliness of the skin, abnormal secretions from the sebaceous glands. Does that make sense? Seborrhea. Rhea means a leakage. All right. But it's not acne. When it's in the scalp, we call it dandruff. But it can occur behind the eye. It says around the eyebrows, behind the ears, the nose, or other areas of the face. All right, so we talked about the 4 grades of acne in detail. Acne triggers and treatments. The triggers can be genetics, they can be hormones, and they can be environment. So you can have like nice skin all your life, and then during puberty, your hormones go crazy, so you have acne. And then you come out of that in your adulthood and it balances out and calms down. Then in pregnancy, you might have pregnancy acne because your hormones are crazy. And then at the end, when you're about like me, about to go through menopause, your hormones are acting crazy again, and you might have acne flare-ups out of nowhere when you're going through that. So all those areas and times of life when your hormones are crazy, you could end up with acne that you don't normally have. Genetics, you know, a lot of times you can overcome genetics with what you're doing, which brings you down to environment. So depending on your air quality, your food quality, your water quality, all those kinds of things can affect. And lifestyle, the type of skincare products and cosmetics you use. I just talked about your diet. So all of these things can be triggers and treatments for acne. All right. If you're going to get medicated treatments, there's certain things that we can do on our level, and there's certain things that you can get from your dermatologist. Some of the medications you can get from your dermatologist, some of these we've heard of, Differin, which is the brand name, Azalex, sometimes birth control pills, right? Because if it's hormonal trigger, then it may be calming down the hormones might treat it. Putting someone on birth control pills strictly for their skin is weird to me. It's worked for some people. Have gotten on birth control for the purposes of being on birth control and noticed that their skin smoothed out. Clindamycin is an antibiotic that kills bacteria. What else? Tretinoin and different forms of tretinoin. My son is on tretinoin for his acne. He's got other stuff going on too. So he's not on isotretinoin, but he's on tretinoin. Spironolactone, I mispronounced that. This is a medication to control androgen hormones. So you will see this sometimes I would think you might use this with someone who's dealing with PCOS, because those types of hormones are what's going crazy, because you'll see them with the male facial hair growth. Sometimes they can cause irregular menstrual cycles and breast tenderness. Tazorac is a retinoid, so it'll thin the skin out. It's a peeling agent. And then Retin A, that's the one my son is on, tretinoin. It's a topical vitamin A acid. It's a very strong peeling agent, so you have to be very careful when you're using anything vitamin A, anything Retin A, retinoid. You have to be very careful to protect your skin, because it will thin your skin out. So you have to make sure you're doing your SPF. Let's see. Okay, so that's just going into a little bit more detail about that. All right, let's talk about PCOS. I have found a video for y'all. We might wrap up with that video. PCOS is it's a big thing that a lot of women deal with. It seems like we're dealing with it more and more and more. So let's talk about these symptoms. It's a hormonal condition that affects 1 in 20 women in their childbearing years. It's also affecting women that are outside of their childbearing years. I see a lot of videos about women dealing with PCOS who are beyond childbearing. So I don't know how, I don't know if I would use that. I don't know if I would categorize it like that if I was to define it, because most of the stuff I see about PCOS is dealing with older women. Symptoms include increased androgen production that causes the development of cysts on the ovaries. Estheticians who work with clients with PCOS usually are clients who have acne, thinning hair in a male growth pattern of baldness, which is sparse hair density at the front and the top of the scalp, but also can cause hair growth in areas that we see on males, like facial. Like a lot of times they have beards and mustaches. And I be feeling so bad for these women when I look at some of these waxing videos. So that's the last point. It also causes abnormal hair growth on the face, arms, thighs, neck, and breast, sometimes on the chest too. You see hair on their chest. It just breaks my heart. That one is a tough one. All right. So that's all it says about it. So I want to go back and see if I can find that PCOS video. Where are we on time? 18 after? How long do we have left in this chapter? Dermatitis, hypertrophies. There's quite a bit left in this chapter. Okay, there's quite a bit left in this chapter. Let me see if I can find that PCOS video to share with y'all, and we'll leave PCOS where we found it. I had it up too. I had a really good one, and then I had to shut my computer down. So let me see if I can find it again quickly. Oh, just by the way, I'm gonna show y'all this real quick. I'm organizing all of my training videos, and I have more training videos than just here, but I'm organizing my training videos into a YouTube page. So I'm putting this together largely for my students. So it's not done, but I'm just giving you a little peek. So that's my little page. I'm starting my YouTube channel, and I'm organizing all of my videos there, but a lot of them need editing. So they're not really ready. So I wanted to give you a little peek about that. I thought it was cute. I found some nice colors. All right, let me see if I can find this PCOS video that I had, because it was a really good one. Is this it? I think this is it right here.
Maybe scared off of the girl Isaac's currently in a relationship with.
Okay, I found it. Let me reshare and share my sound. I was looking at the little lesson plan, and it was saying to find a good video on that. So I did that. Let me know if you can hear it when it starts.
Polycystic ovary syndrome, also
Can you hear that?
Yes.
Okay, cool.
called PCOS, is an imbalance of the female sex hormones. The ovaries are part of the female reproductive system, along with the fallopian tubes, uterus, and vagina. Your ovaries contain your lifetime supply of eggs. These eggs are immature and are stored in tiny, fluid-filled structures called follicles. Your pituitary gland, located at the base of the brain, produces hormones that direct the function of your ovaries. Each month, the pituitary gland secretes follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH, into the bloodstream. After these hormones reach the ovaries, several hundred immature eggs start to mature, expanding the size of the follicles. As the eggs mature, the follicles secrete estrogen, the main female sex hormone. Once the amount of estrogen in the blood reaches a certain level, the pituitary sends a surge of luteinizing hormone to the ovaries.
shall we?
Trey, these are
causing the most
very
mature follicle to open and release its egg in a process called ovulation. The free egg travels through the fallopian tube where it awaits fertilization. Eventually, the remaining immature follicles and eggs dissolve. If the egg is not fertilized, the egg and the lining of the uterus are shed during the next menstrual period. If you have polycystic ovary syndrome, your pituitary gland may release abnormally high amounts of luteinizing hormone into your bloodstream, disrupting your normal menstrual cycle. As a result, your follicles do not mature and ovulation does not occur, which can lead to infertility. Some of the immature follicles do not dissolve and remain as fluid-filled sacs or cysts. In addition, your doctor may find your blood has high levels of insulin, a hormone produced by the pancreas. Too much insulin, combined with high levels of luteinizing hormone, can lead to excess production of a male hormone called testosterone in your ovaries. Abnormally high levels of testosterone prevent ovulation, which can lead to infertility. High levels of testosterone also cause many of the physical features associated with polycystic ovary syndrome, such as acne and abnormal hair growth. Having polycystic ovary syndrome raises your risk for type 2 diabetes because of excess insulin and insulin resistance, heart disease, high blood pressure, cholesterol abnormalities in the blood, and endometrial cancer. Since there is no cure for polycystic ovary syndrome, your doctor may recommend one or more medications to treat your symptoms, such as hormonal birth control, which, while preventing pregnancy, also regulates your menstrual cycle and reduces testosterone production in your ovaries. Anti-androgen medications, which reduce abnormal hair growth and acne. Diabetes medications, such as metformin, which lowers your insulin levels and regulates your menstrual cycle. And fertility medications, which can stimulate ovulation so you can become pregnant. If you want to become pregnant and fertility medications have not succeeded in restoring ovulation, your doctor may recommend laparoscopic ovarian drilling. During the procedure, your surgeon will insert a small needle into the ovary and use an electric current to destroy small areas of ovarian tissue where testosterone is produced. Over time, testosterone production diminishes and ovulation may occur.
Really confused at this point.
Okay.
Hey guys, welcome to Forward. We're a new type of doctor's office that's providing
Situationship.
Does that help give a little bit more color and clarity to PCOS?
the right thing and shut this down. So are you that serious?
I did think there was something.
Yes, it does.
All righty. Okay, so we will pick up with vascular disorders. Let me share one last time so y'all can see what we're about to do next time. We'll wrap this chapter up and we'll look at disorders and diseases of the eyes from the last chapter. So we'll go through pigment disorders, vascular disorders, pigment disorders. These are pretty interesting. Different types of dermatitis, different types of hypertrophies. What are hypertrophies? Overgrowths. So keratomas, keratosis, hyperkeratosis, moles, skin tags. The 9 contagious skin diseases. These are probably, this is a very important section to really familiarize yourself with so that as you're moving forward with like treating clients, you can recognize out of all of it. It's important for the client's health to recognize things like potential skin cancers, but for your safety and health, it's important for you to recognize those 9 contagious skin diseases because you're the one at risk on working on a client who has these, right? So that's an important section. We'll really go through that. And then we mentioned those mental health conditions that sometimes manifest as skin conditions. And then the common skin conditions, edema, swelling, erythemas, the redness, folliculitis, pseudofolliculitis. We'll talk about those. And then the sudoriferous gland diseases or disorders. What do we say? What were sudoriferous glands? We always talk about sebaceous glands, but what are sudoriferous glands?
Sweat glands.
Sweat glands, so all those sweat disorders. And then that will be the summary and review for this chapter. And then we will look at diseases and disorders of the eyes. So we'll wrap these 2 up next week.
Okay.
All right, so this is chapter 4 in your fundamentals. If you haven't gotten a chance to get this started, go ahead and get this started because technically the due date would be Sunday. And then the last one, we'll have to just extend some grace on that because I think nothing has really changed. Jasmine, you got access, and Maris, you still do not. And Nisha, you had it. Is that correct? Access to the LASH course?
Mhm. That's right.
Okay. And Amaris, you still don't have it?
I don't.
Okay. All right, so do what you can, work on what you do have access to. Seven's not here, so I can't really check on that right now. And he's a little difficult to find right this minute. So do what you can. Also, last thing, more so for you, Nisha, than anybody else, let me go ahead and stop the recording. Let's go ahead and pause it here.